Sure. Thanks. Hi, everybody. We wanted to remind folks, and this is going to be something that we will present kind of at each of the webinars, just to keep us all on the same page about what we as a collaborative are doing for this particular project. So this is the statewide hemorrhage driver diagram. What you can see is that we have our SMART goal over on the far left, which is to reduce severe maternal morbidity in women who have a hemorrhage by 20% by the end of December 2020. You can see that our key drivers are readiness, recognition, response, and reporting systems learning. That should all sound really familiar to y'all because the AIM bundle, Hemorrhage bundle, organizes their recommendations into each of those as well. And so each one of the inputs for those particular key drivers are over in the right-hand side. And those should also look familiar because those are our structure measures and our process measures that we're collecting every quarter. It's really exciting. I know in this call we have folks that are in very different spaces with regards to their implementation of the hemorrhage bundle. Some are just now starting up with us, some have been with us for a while, and some could teach the course and have been doing this since A1 initiatives, et cetera. And we're really lucky to have that wide variety. But for that reason, we think it's ever more important to just remind everybody about how this all fits together and how you at your individual hospital levels can also utilize this driver diagram, but change it as is necessary for where your hospital is. In addition to having different folks in different spaces in their implementation plan, we also know that we have very big hospitals and we have also hospitals that aren't very big. We have hospitals with big teams for QI and those that are, it's kind of like a one-person show getting everything done. And so we want to be mindful of that and try to make it as easy for you as possible. So please do take note of the driver diagram, but then also feel comfortable in changing it as necessary for your unique system. Let's go to the next slide, please. In order to guide us through how we look at that driver diagram, there are so many different components to and interventions listed on that previous slide that we wanted to highlight some of them that we thought might be most impactful, that we wanted folks to really, that we wanted to track even more closely. Obviously, we want all hospitals to do all of the things, but we also know that sometimes it's easier to focus in on a couple of things that may, again, either have a bigger impact or may require kind of the minds on this call. So we narrowed down our goals. And again, that SMM goal is just as we discussed on the previous slide. Thinking about a couple of process, and there's an error on this slide, I apologize for that, and one structure measure, we came up with the following, that from a risk assessment standpoint, which is a process measure that y'all are reporting on every 3 months, that we would like for the number of women who have a hemorrhage risk assessment with risk level assigned performed at least once on admission, that for that process measure that 100% of hospitals are doing that, hopefully 100% of the time. Debriefs is actually a structure measure. Apologies for that, but that we can help hospitals work towards doing debriefs on cases that require greater or equal to 4 units of blood or admissions to the ICU. And then similarly, we're hoping to get to 100% of hospitals that are doing quantified and cumulative blood loss documentation. And in the next couple of slides, we'll talk through kind of where we are, or where y'all are, as far as achieving these goals. But before we do, I want to just pause and see if there are any comments or reflections or questions about this overall driver diagram and these goals that we've just presented. And as Diane mentioned, you're welcome to unmute your phone and ask your questions or do the same in the chat box. Awesome. The other thing for folks to share, if you are a hospital that's having difficulty getting senior leadership buy-in, the Joint Commission announced just recently that they'll be looking for hospitals to be putting into place the hemorrhage bundle and the hypertension bundle. So that may be something that really helps if you don't have that type of buy-in, that might be something that helps get that kind of high-level buy-in. And I'm going to put the link to the form here in the chat box so y'all can have that just in case you need it. Nope, that's a resource that's coming later. This is very exciting. I have many windows open right now. Let me see if I can do this correctly. That's it, the one that says Joint Commission. Okay, sorry about that. Next slide, please. Diane, did you want me to go through this, or did you want to do this?
I'm happy for you to go through it, and I can chime in.
Sure. So this is super exciting. These are the process measures for hemorrhage since we started this. Now we have over a year of data collection on our process measures. And you can see how we have 6 different process measures at the bottom. They're all color-coded. If you take a big step back and you just look at it, you're like, this is awesome. The goals of all of these things would be to go up. And every single one of the process measures that all y'all are reporting on are heading in the right direction. And that is truly spectacular, like truly spectacular. So I'd like to highlight a couple of them that are particularly impressive, I think, in that thinking back to what our goals were from the previous slide. If we look at the kind of brighter, darker blue, the risk assessment field, again, this is something that just about 1/3 of hospitals were doing at the beginning. So 1/3 of y'all were assessing a woman's risk for bleeding at the beginning of this initiative. And at the end of Q2, 80% were reporting that that was happening, which is just truly phenomenal, truly phenomenal. And then the green line, which is something that we're going to talk a little bit more later on today's call, is that the quantified and cumulative blood loss. That one is probably one of the biggest lists that hospitals have to do because it is impacting so many folks. It's not just, oh, thanks for that pointer, lovely. So we can see how it went from 1/3, so 33%, and now approaching 70% of hospitals are doing that for folks in labor and delivery. That is huge. That is absolutely huge, and we know how difficult that is because it requires education and communication for your nurses, your providers, your anesthesia team, in labor and delivery, on the postpartum unit. Like, it involves the whole team. And so I think I'd really just like to highlight and congratulate y'all on that. The 2 areas that I think are linked that we have an opportunity to work on are our provider education, and both have had some really nice increases. I think that speaking as a provider, I know how difficult it can be to not only get all the providers to complete education, but one of the biggest challenges there is to make it so that we can get it documented. And so it's both of those things. And we've been talking with some of our leadership team members about how we might be able to facilitate and help hospitals continue to have that increase. Anything that I missed on this slide that you wanted to highlight? I'm just going to throw that to Diane or Lauren or Truro.
No, I don't think so.
Okay. We can go to the next slide then. These are our structure measures, again, taking a step back and just looking at the overall big picture view. Everything's going in the right direction. Looking at our hemorrhage cart, we went from just over 50% having hemorrhage carts to now, look straight at 90% of folks have a hemorrhage cart. That is a huge win. Huge win, particularly for hospitals that might be at a smaller institution. Having all of those things immediately available and ready for those experiences when hemorrhage happens is really pretty exciting. Also, thinking back to our goals, one of the key areas that we wanted to work on was debriefs. And so that's the orange line, and you can see we started with just over 20% of hospitals indicating that they were having those. Now to full on 2/3 of hospitals saying that they're routinely having those. That's a really impressive gain, and it shows that that is something that y'all are actively working on. We're going to talk a little bit more about that particular structure measure in this call as well. But I think just as a takeaway, everything's heading in the right direction. When we look at the structure measures, areas for opportunity, or that I think are opportunity for improvement for us as a collaborative, look to the light blue line and the gray line. And so the light blue line is the patient, family, and staff support. It was pretty rare for hospitals to have something like that at the get-go. And we now are over 40%, so have more than doubled the percentages of hospitals that have that kind of thing. But still, this seems like an area, it's a structure measure. This seems like something that we should be able to help each other focus on over these next couple of months. And then multidisciplinary case reviews, that similarly is something that, while it has increased, is something that hasn't increased as robustly as the other structure measures. So that is something that we'll be looking forward to hearing from other hospitals that have a strong and successful multidisciplinary case review process to maybe share some pearls of wisdom about how folks are making that happen. But just looking at this as a big picture, it's really pretty impressive what we're seeing from y'all. Any other comments from the team or questions from those on the call?
Hey, it's Diane. I wanted to throw out one thing. So while we're kind of looking at this slide, and throughout this discussion and presentation, if anybody has any thoughts or suggestions about the type of technical assistance that might be helpful around some of the areas where the growth hasn't been as steadily increasing, if you have any thoughts or can identify what maybe some needs are that we could help put together or support, that would be really great if you want to type that in. Email us later or speak right up on the call. And the other thing, what Dr. Kottke shared about, we'd love to identify some pearls of wisdom around any of these areas. So if there's something you feel like it's been a great success in your hospital, please let us know, especially with the case reviews and the patient and family support.
Thank you for that, Diane. Anything else? All right, Trill, can you go to the next slide, please? So we follow the structure and process measures because they're a little bit easier to trend over time, and we get the feedback a little bit closer to real time. The outcome measures, y'all remember that there are 4 outcome measures that we follow for each of our initiatives. And so the obstetrical hemorrhage outcome measure, severe maternal morbidity among hemorrhage cases, and then those without transfusion codes also among hemorrhage cases. What we can look at, these take a little bit of time. These come directly from diagnosis codes that happen at hospital discharge. And so providers at your institution do a diagnosis code. Those discharge data get shared with the Georgia Hospital Association, and then that gets shared with GaPQC, which is amazing because then we don't have to go through all of the charts to get all of this information, but it does have a little bit of time to get the data. But what you can see here is that we have how the severe maternal morbidity has been looking over the past couple of years, and keeping in mind that we really started going at about Q2 2018. And so hopefully on a future webinar, we'll be able to get a little bit more granular information from our EPI team and dig into numbers, dig into differences across race, ethnicity, and potentially region and kind of other things that we're interested in looking at. But it looks that at least sort of our SMM among hemorrhage cases may have been trending somewhat down since prior to initiating any of this work. Next slide, please. We asked y'all to fill out a survey about a whole bunch of things as kind of a midpoint touch about where your hospital was, to get a sense of how y'all all are doing, because again, folks are in many different spaces. We also asked what people were most interested in hearing about, and so what we can see here is that folks were most interested in hearing about simulation drills. 80% of people were like, that's a great idea, followed by staff communication, huddles and debriefs, implementation of the risk assessment, and then maternal mortality data from the state. And so over the next bit of time, we're going to try to hit on the majority of these topics. And one of the questions that we will want to pose that folks can answer now if you're interested, or it can come later, is this idea of simulation drills and how logistically we might want to have that occur, be it in person. What capacity does your hospital have for in-person simulation trainings and things like that, because that would be something that GaPQC would be happy to help facilitate. Lauren or Diane, did you guys have more to say about that particular concept?
I've actually got a slide to kind of prompt us again back to that a little bit later on.
Okay, sorry about that. Just jumping ahead for fun. Okay, we can go to the next slide then. This was a question that came up from one of you all. Lauren, do you want to set this up?
Can you hear me?
I can now.
Yes. So we really wanted to be able to get feedback from you all on the call. The question came up, and I know that I've had this conversation with some of you as well. What happens in your facilities when there is conflict between physicians that are not yet bought into the bundles and QBL, and they insist on documenting the estimated blood loss, and the nurses document, quantify the blood loss and document that accordingly. So I just wondered if there was anybody on the call that would be willing to share if you, A, have this problem and how you were able to overcome that, or B, what you do at your facility if you have this very issue.
Hi, this is Marcy from Epsom.
Hi, Marcy.
So We have this exact issue, and one of the things, it wasn't an education thing that the physicians just didn't know. A part of it was the EMR documentation. So instead of giving our physicians a choice to choose EBL, we've changed the documentation to say QBL, and they've put it all on their favorites list, so when they pull their documentation for documenting, it reflects QBL instead of EBL. We're also reviewing our EMR for other areas that's pulled to our area to make sure that they have, when they pull their documentation up, like the OR, for instance, they're able to put QBL instead of EBL.
So, Marcy, I guess, thank you for explaining that. I just want to drill a little bit further. Are they actually documenting QBL based on what the nurses are measuring and telling them, or are they documenting their estimated blood loss in a field designated for quantified blood loss?
Well, we had both. We had one physician that just basically says, you don't need to do that, this is what it is. But our nurses are now very verbal and say, no, we've waited, and this is what it is, so this is what we're documenting. And for the most part, that physician changes his documentation to match his ours and is not insisting that it continues to be what his estimation is. So it was a two-part. We were doing both of those.
Good. I'm actually, thank you for that feedback. I'm actually seeing some responses from other facilities. Jennifer said we let them still document EBL and the nurses document QBL. We did that to compare the difference so they could see it. And Jennifer, I don't know whether you're willing to speak to that if you want to unmute. So do the nurses document QBL? Do the nurses document QBL
yes,
even if the doctors estimate EBL?
The nurses are documenting the QBL. The physicians, I think they still have some physicians that are documenting EBL if they are leaving the delivery or the C-section or the OR prior, or if they've got to run to like another case or something and they get out before, they may document the EBL. But I know anesthesia also has changed in their documentation from EBL to QBL.
Okay.
So I know the nurses are documenting QBL, and I think the physicians are documenting QBL when the nurses tell them the QBL.
Okay. And so this is a question for Jennifer Collier. Thank you. You said the nurses do the whole process at your facility. You said that you wanted to compare the difference between estimated blood loss and what the physicians noted and the QBL. Was there a big difference between that? And Jennifer, Jennifer Collier, you can respond in the chat box if you want to, somewhere, but they're mostly not. So again, that's the argument for us to continue recommending doing quantified blood loss because it's best practice.
Hi, Lauren, it's Dr. Baker. Could I ask a question?
Hi, Dr. Baker. Yes.
Real quick. So I was wondering, because I'm a little bit baffled, and I think we had this conversation at the last annual QPC meeting about, since we know that these are best practices and we have, data to show that it works, have we really considered reaching out to the department chairs at our participating facilities and just kind of asking them to recommend to their medical staff that we institute using QBL and documenting QBL, and that our documentation is consistent across the board? I was just curious about that because it just kind of seems a little strange that
we're still having
some
some
that are not leading. Yeah, that they're not leading the charge on this. In fact, my nurses know that I want to know that QBL. And so they're going to calculate it, and they're going to, they're starting to tell me, okay, I've weighed everything, and this is what it is. But it's a little, I'm kind of baffled by it. I'm like, well, why, why are we kind of having this push and pull about what's documented? So I was just wondering if maybe we had thought about getting some information to the department chairs and kind of having the OB chairman or chairwoman say, hey, we really expect you guys to document QBL.
I think that's a really good idea, which is concurred by Dr. Kottke as well. Has any of you on the phone had to get to the point of getting? I know Jennifer Boland, you at your facility, you got the medical executive committee. You got their buy-in to do these elements of the bundle. Any of the other hospitals? I'm just reading here in the chat box. Courtney says, one of our physicians that supports QBL, that blood loss for delivery is pending. Quantitative measures if he needs to leave the unit before the nurses have the final number. Yeah, how has anybody had to kind of escalate or this to a higher level if they haven't had buy-in from the physicians? But I definitely appreciate your feedback, Dr. Baker, and maybe you can help us and with Dr. Kottke and Diane and Terrell, maybe to make some recommendations about how we would suggest to the hospital teams, or whether we do that ourselves through GaPQC, to reach out to these OB chairs about this best practice.
Yeah, I would be happy to help. Just, I think that it's just more of a coordinated effort, getting everybody on board and saying, okay, guys, this is what we're doing. I mean, it's the same as with sepsis. They expect that you have documents, So we just kind of need to, I think, maybe help our chairs to communicate that effectively. And I think it would be really easy to just give them a one-pager and say, look, this is why we are doing it, and we really need everybody to do it.
And I don't know if everybody can see in the chat box, but there's Courtney Kephart had texted in and added that one of their physicians that supports QBL charts that blood loss for delivery is pending quantitative measurements if he needs to leave the unit before the nurses have the final number.
That's good. Yeah. And also, I did see somebody, Jennifer had written that it's tough to get started and to keep the nurses doing it. So we do know that it's not only a physician issue, it's how do you keep your nurses, motivated to continue. And Kathy, thank you for your feedback. Some providers have voiced that they don't like the impact of their numbers, showing more hemorrhages when they quantify. And I agree totally. Finding physician champions and getting department heads involved has been the key. So we can see that there's some common themes there, and there's some good practices that others are doing that may be helpful for others. I know some recommendations. Sorry, go ahead.
I'm sorry, Dr. Baker. I was just going to say that, too, it might also be really great to offer to the OB departments some of the nuts and bolts of making this work. And I've been very, very pleased with the way that the nurses have responded at us in terms of like our OR nurses and the nurses in the labor and delivery rooms, just figuring out a way to get the most accurate number as possible. So like we don't wet our sponges during our C-sections, so that we can kind of keep up with that. If you don't have access to the technology that will actually read your sponges, I think that that just sometimes figuring it all out takes a little bit more mental gymnastics than people have at 2 or 3 a.m. when they're doing a C-section or a vaginal delivery. So maybe just even sharing some of those, very practical ways of how you do it. I know I do some part-time work at another hospital, and when I was able to kind of show them the way that we do it, they were like, "Oh my gosh, that's so much easier. We can get that quickly, and it's not so cumbersome. So I think that making it easy is probably the best way to get more physician buy-in.
Yeah, that's great. Thank you. I know another recommendation that was brought to us was for hospital teams to develop a scorecard. We received some feedback from someone from another state, and what they actually did was do some chart reviews and look at the physicians that were doing well with their QBL, and they created a scorecard, and very similar to the way that we do with the reports where it was de-identified, but each individual physician knew whose report it was. And of course, you know, nobody likes to be called out, and that was that seemed to have been a success. So I'm not sure if any of you would be willing to attempt to do this. I can certainly find out the information from where it was done and share that with you if any of you are willing to take that step to do that. But that's another thing that could probably help change some practices. Any other comments or recommendations or suggestions to this question?
Thank you all.
Yeah, thank you. And we'll just keep the communication open. If you want to share anything at a later time, please let us know. And if you have any recommendations, we'd be glad to share that with others. Thank you.
Lauren?
Yes.
I had one question not related to the QBL, but one of the initiatives that we're trying to get off is the support for the family and the patient. I'm just curious as to what others are doing.
Yeah, thanks for that question, Marcy. That was one that we had thought about as well. Diane, did you have something to speak to this?
Yeah, so there is a document. Hold that thought for just 1 second, Marcy. And that is something we would really like to explore. Go ahead and take us to the next slide, Sherrill. I'm sorry. Please go ahead.
No, I'm sorry. Go ahead. I was just about to add to that in terms of the family support, the debriefing. You know, because oftentimes there are nurses, you know, may have several, for smaller facilities, maybe only have 2 or 3 nurses, and they may be taking care of other patients at the time that this happens, and then we don't really get a chance to debrief before the end of the shift. So I was wondering what other places are doing with that debriefing process to try to involve a multidisciplinary team that actually took care of the patient to debrief.
Well, and on that note, thank you, Dr. Baker. Terrell, would you bring up the next slide? Because that's perfect timing. You just set this up perfectly for us. We did want to go through and ask for exactly what you just mentioned. We've got up a tool. This is a sample tool from California's PQC of something that they have, or at least had at one time, in place for how they what they use for their debriefing. And some of the documentation that they had shared about some of the issues around it. And so I think one of our questions was going to be, would it be helpful for us to develop something like this, just as we talked about earlier, having a group work on something on the hypertension call? Would it be helpful to have, you know, a group of people come together and let's develop something that we could share out as a resource for people who would be interested? And Dr. Baker, I think you say your question again if I don't get this right. But you're asking how do others overcome the challenge, especially in a small facility, with being able to do a timely debrief with limited numbers of staff.
Yeah, that's exactly right. I was actually thinking about, I know that Marcy had been very creative about coming up with a debriefing form and making sure that we have all the elements, but I was actually thinking about maybe trying to turn it into something electronic where people could give their input or needed to give their input within, say, 48 hours of the event, and we could look at it that way, because I we had actually a significant hemorrhage last week, and I tried to debrief with the team, but I've got folks who need to be in the OR. It's like 6 a.m. They've got to go. The nurses are supposed to be getting off. People have their kids ready for school. So, in trying to gather that group, it was just impossible. And so I thought, okay, well, I can try to debrief with some folks later tonight when we come back on for the night call. But it wasn't the same team, the complete same team, so some people just were kind of lost. So I would like to capture that feedback, and I was thinking just a simple survey with the questions that, might be 5 questions or 10 questions that they can just, indicate a response to, like what would they rate our, how we responded to that particular hemorrhage, and how do they have comments about things we could have done better, or what areas could we have done better in. So that's what I was thinking, but I was wondering if anyone had come up with a really good system and that they're using already.
That's a really great suggestion.
How is the best way to send an electronic document in a hospital setting? Is that an email attachment? Is that something else? What are kind of some of the options that we could do? I think it's a great idea as well.
I was thinking text. I know that our overhouse supervisor has a way to send a text message to the entire team. Like everybody that she calls in, the surgeon, the tech, the anesthesia team, and I was thinking that, and I don't think we necessarily have to have patient information involved in that, but just like, how soon did we respond? Could we have done better? How did we talk to the family members? Did we remember to have the hemorrhage cart available? Did we go through the algorithm? Like, how do you rate our response as a team, and be able to kind of gather that data electronically, and then it's really easy to share and to look at.
Yes.
That's
Dr.
really
Baker, this is Missy Kottke. I love all of the things that you're saying right now, because I agree that this tool, it's super helpful to have a tool, but I would love to see more of the specifics that you're referencing about, right? Like we had our hemorrhage cart. It was full. We used it. All of those kinds of really pragmatic, helping folks kind of do their own little fishbone of the event, and then thinking through what could or should be done for the next event, because there'll be another. So I really appreciate the comments that you're having already.
And we just had a question in the chat box referring to this, that if anything was created, could individual facilities edit it to taper it for their own facility? And I'm sure that that's easily done, because not everything's going to happen in the same way. But I guess if we had some kind of framework, an outline of the type of questions, it could be modified to get the responses to provide appropriate feedback. So thanks for that question.
Yeah, absolutely. I mean, my idea, I'm not that, savvy, but I was just like, why don't we make a Survey Monkey link? Yeah. And I think everybody could have their own. We could provide the general questions, just based on the things that we want everybody to have. And then also, just if you have some individual questions that you want to ask, like, was the cart located in the medication room, or whatever individual questions people have, they could make their own link, and I feel like we could share that amongst each other, like what questions are you asking, because that might help us dig down on some things that we really need to flesh out at other facilities. So maybe we could just share those questions with each other, and people can modify it based on what they need. I just hate the idea of another form where the nurse is already, trying to chart. And Marcy and I talked about it. I said, they've been through a traumatic experience. They're working as fast as they can, and they have to sit down and chart everything. And then at 8:30, when they're already an hour more late leaving from charting, it's like, oh, and by the way, fill out this debrief form. It's kind of like, ugh. So I think it would be great to have people be able to do it at a private, quiet moment where they can sit down and actually put their input in, and then we don't have to hold on to the paper, but we can see the actual data in graph form.
Great. And we would love if any volunteers would like to work with Dr. Baker, who's been nominated, and of course the GaPQC team to help to put this together. This would be really helpful, and then that way we're getting your voice as those that are the hands and the feet on the ground, and knowing exactly what would be appropriate questions to ask. So if you're willing to to participate in that, you can either respond in the chat box now or send one of us an email to let us know, and we could get working on this really great idea.
I think it's something that could be done relatively easy. And shared back out and get feedback and get it down to something, and then we could have the option of having it as a SurveyMonkey link or an email document or a hard copy document, whatever best fits your setting, and maybe that's a combination of things.
Great.
Thank you.
Thanks, Dr. Baker.
Yes, thank you.
Oh, no problem. Marcy and I will work on transforming ours into a SurveyMonkey link, and then we'll be happy to share it. And if anybody else wants to jump in, you're welcome.
Thank you.
Thank you. Okay, Terrell, can you go to the next slide? Dr. Kottke, can I ask you to jump in on this one, please?
Sure. So one of the things that we noted from that we just discussed earlier from the I'm having a word-finding problem, but from what we're doing for patients, our structure measure of patient, family, and staff support is the measure that we are that we have a lot of opportunity for. And we started talking amongst ourselves to kind of understand what resources we've identified that could be available for patients and their families after having gone through a massive hemorrhage, after, going to the ICU or recovering from kidney failure or losing their uterus. Like all of those things are big things. And I think that there is this, immediate relief when you're able to debrief with someone because they're alive and you help them get through that. But then now what can we do for them going forward? And the extent to which is this something that is potentially going to be a future problem for them, et cetera. So this is the next two slides. We'll go through them kind of one at a time, but this was the link that I accidentally sent out first during this call today. This came from North Carolina's Perinatal Quality Collaborative. So most of these are national references, but they are references and resources to support people who have experienced postpartum hemorrhage. And there's a ton of resources here. I will admit many of them I did not know existed. And so we thought that we could share this with the group today so that certainly you can modify this if you like it. This is something that we could consider, modifying and branding with a Georgia label. We do have some local resources for families in Georgia that we'd want to have on here, but just wanted to share this with the group and then to pose two questions to you all. The one is, do y'all have any kind of patient family specific means to support folks who have gone through obstetrical hemorrhage? That's the first question. If you have something with the sub-question of would you be willing to share it? And then the second, Dr. Baker, you had mentioned while we were talking about debrief something that I think is so important, and that is support for staff, because they too have just experienced something that could be potentially pretty traumatic for them. And I actually don't have anything right now as a resource for supporting staff after having gone through one of these really intense experiences. And so that would be the second question that I have for y'all, if you do have something and what it looks like. let's start with the first question first. So do folks have any resources that they're currently providing to patients who have gone through a severe postpartum hemorrhage? We believe that 43% of you say that you do.
Hi, this is Jennifer at the Medical Center. We don't specifically have anything that's labeled specifically for like women's services, but we do have a transitions team, which is a group of counselors and grief counselors and things like that we are able to consult, and they come in and they talk with the family, and they put them in touch with like community resources and things like that. But they are actual counselors.
And do you, what kind of initiates them to participate and come and talk with the patient? Is that like an order that has to be done by the provider?
Yes, it's just an order that's placed in for transitions consults. They do a lot with our palliative care, our in-hospital inpatient palliative care. And then we have Wings of Hope, which is our pediatric side to that, and they help with like our perinatal losses and things like that at this time. But yes, it's an order for transitions consult.
Thank you. Do any other folks have any resources that you're offering for people who have had experienced postpartum hemorrhage? And do folks think that having some, oh, sorry, go ahead.
This is Jennifer again. I was just saying that also sometimes I don't think people, or maybe we don't realize it, but our pastoral care, they can also be consulted to speak and help with, or your chaplains, whichever you have for your facility, but they can help with that. And as I know we're talking about patients and families, but as for staff, we have a really good EAP services at the hospital that, you know, if the staff is really having a lingering problem, that they can seek out with our employee assistance program for some counseling and stuff.
Thank you. Would folks find that having a resources sheet like this kind of recreated for Georgia, would y'all find that to be something that would be helpful?
Yes. Yes.
Okay. Great. If anyone is interested in if you have additional resources that are locally relevant that you would like to see added, or you would like to help formulate this into be Georgia specific, please do type your name into the chat box. And then we will, I think the staff support is something that maybe we want to noodle on and see what other folks have resources. I think EAP is a great program, and we can think through kind of what other resources are out there to help support the team. And maybe we can help kind of connect some of those with the debrief that Dr. Baker and Marcy are hooking us up with. Great. Thanks, y'all. Terrell, can we go on to the next slide, just in the interest of time? This is just the flip side to what you just saw on the last slide that has a bunch of other places, Facebook support groups, etc. Next slide. This is what we're thinking about for the next several webinars here over the next couple of months. So we'll be doing discussing simulation drills on October 1st. November 5th, maybe we'll be able to have an actual debrief document that we'll be able to share and hear some folks' experiences with it. And then in December, patient and family education. The other thing that we're looking forward to, I'm So thank you all who participated so much on this call. I think it was particularly helpful to hear what hospitals are doing. And so we'd like to formally incorporate that into these webinars in the future. So I think in October we are going to hear from one of our hospitals about how they've integrated risk assessment into their setting. And then we'll be thinking about other ways to hear formally from y'all about the ways that you're incorporating components of the bundle or something, that is adjacent to management of obstetrical hemorrhage. So we'll be looking forward to hearing even more from y'all going forward. Diane, do you want to make any other comments about that?
I did. We asked the outreach educators from the regional perinatal centers a couple of weeks ago their thoughts about simulation drill training and debriefs in particular. And because there's been different requests over the last couple of months of hospitals who have acknowledged that they could use some additional assistance in developing or maybe improving or expanding on their process, especially around drills. And there was some discussion about would it be helpful to have some type of face-to-face meeting. I'll tell you the thoughts. Dr. Kottke had a thought earlier today that was very good about we had planned to offer some kind of a formalized quality improvement training this year, and maybe to do it in a combination, have that for a few hours one day, but then also have this technical component. And I think what we wanted to hear from everyone is, number one, if we were to do that face-to-face, if we even maybe made it available regionally, would hospital staff be able to attend? Would that be helpful, or do we really need to kind of confine what we're doing to maybe this type of a format? So I'd love to hear thoughts about that.
So this is Dr. Baker, and one thing that I would love to see, this was an idea actually that I had a long time ago that Marcy has started to work on, is making things a little bit more accessible, like maybe if you did decide to do an in-person meeting, that you record those discussions or even presentations so that people can go back and look at them. And our hospital recently got a YouTube page. So, in terms even of the postpartum hemorrhage resource for patients, a way that we can say to them, hey, you're watching this because you had a postpartum hemorrhage, and be able to pull that link up upon discharge so that patients understand what happened, that they did have a postpartum hemorrhage, that they need to talk about that with, future pregnancies, and that they need to list that as a part of their medical history. But also just kind of having those presentations available to staff as well. And they don't necessarily have to be super long, but they could be a part of like health streams or other platforms where staff is getting education, so that they're kind of grabbing those things. I think it can be really difficult, even within one facility, to get all the staff in one room at one time. So, for those who can attend, and if you have some staff or physician champions, that's awesome. But I definitely think recording some of these conversations, because I've been to some excellent presentations, and I think they would be helpful for everybody at my center to be able to see. But, someone has to actually be taking care of patients whenever we have it. So I think that maybe even recording some of those and making them available to folks and saying, this is from the Georgia QPC, and this is some discharge teaching that you can roll your workstation in the patient's room and show to them about postpartum hemorrhage or hypertension. I think those might be, 2 or 3 minute videos that could really give a patient a lot of information.
Thank you. That's great feedback.
It's a great idea. And in also thinking about education and drills, we know that not a lot of facilities have simulation models, and we're thinking about doing this in conjunction with the regional educators that you're familiar with. So that will help to provide some guidance on what do you do if you don't have anything? What if you don't have a lot of stuff? And there are lots of creative ways that, a training like this, a hands-on training, if you're interested, would be able to help you do what you can with even limited resources in your facilities, but would still be effective with helping to run drills in your facilities. So those are some of kind of the ideas, and we just want to know whether you feel that it would be helpful for you and beneficial. And like Dr. Baker said, some of that could be recorded for staff, and obviously we also need to think about resources that we could have available for patients in the same format.
Lauren, this is Jennifer Rozovich from Augusta. I know you called, but I was thinking about something while I was listening to all this as far as the simulation drills go. And one of the things that they've done up here is that they've made the nurses basically responsible for making sure that the drills get done, and it counts toward their clinical ladder. And I think that's a good idea just because, spread the love. Not one person. It's not all on one person. And then when that person, that nurse is responsible for it, then I think she learns a little bit more about it. And I think, we could get the docs in on that too. If you could have them somehow, have a doctor and nurse or some kind of team. But I think that's a good thing that I hadn't seen or hadn't heard anybody talk about so far with drills.
That's a great idea. So do they do that? Do they do that during downtime? Do you have a specified day to do that? Or is it part of the nurses' ongoing learning that these individual nurses will take it upon themselves to create these educational sessions?
Well, they're doing it quarterly, and they do select a day. It is supposed to be a surprise. Only the nurse that's responsible. Sometimes that doesn't work out well, but. And we've done not only the hemorrhage ones, but also some newborn resuscitation as well, which was very interesting. Interesting what they think they know, but then they don't know. And so I think all these different resources, electronic resources. Of course, they called Johnny and I because, we're the outreach educators and happen to be located there. But I just wondered if any of the other facilities, the larger ones especially, were using this as part of what their nurses could do for their clinical ladder.
That's a great idea.
Hey, Lauren, this is Jennifer at Jennifer Bowen from the Medical Center. I did like a small simulation workshop for my regional nurse managers, and we just kind of spent the day. Rachel from Savannah also came up and helped me with that, but we just kind of did a day where we just kind of started with like what simulation actually is, and that it doesn't have to be this really extravagant, high-fidelity thing. It could be something very simple that you could do just even if you wanted to have, check your nurses off on simply taking a blood pressure correctly or anything like that. Just something even so simple as that. But we did it, and then we kind of went through each aspect. And I think one of the first things that people have to remember is that when you're going to do the simulation, before that even starts, what is your main objective? What is it that you want your nursing or your team to accomplish?
Yeah.
You can't, and if you think about running a hemorrhage drill, it is one of the harder drills to run, I think. So if you're looking at the AIM hemorrhage bundle and you're thinking, oh my gosh, we've got to do all these things in one drill, I don't think that's necessarily true. Like we did just a small QBL drill to start with, and then we kind of moved in. The next time we did a drill, they went in and they were getting report, and they had to identify her hemorrhage risk, and then they started a QBL, and once they got the QBL accomplished, then they simply had to demonstrate initiating the hemorrhage protocol. So we didn't move through the whole entire hemorrhage protocol, but we figured if they could recognize a hemorrhage and they could accurately quantify QBL and then they would know how to implement that hemorrhage protocol, then we would be moving in the right direction to work into a big hemorrhage multidisciplinary team simulation.
I love that. That's great. That's great. And
that's a great idea.
We'll be reaching out to you if the hospital teams are wanting to do this, and we can continue to expand on what you're doing regionally. I think this would help because it would be something that's in their local region, and they'll be able to get some help with hands-on. So this is something that we'll definitely love to explore, and we'd like to hear feedback from those of you that are on the call. And we know some aren't on the call, and maybe we'll send that out to get some feedback. And if it's something that people want, then we can start planning on what that might look like.